Hello and welcome. This is another installment of how to talk to your clients about their health needs. We have four fabulous facilitators from the UCLA School of Nursing. I will let them introduce themselves as they are about to do their specific part of the presentation. And first, before we jump in, I just want to greet Elizabeth and say if you could do a quick introduction.
Oh, thank you so much, Carrie. So we're so happy to be here. We're here with our nursing students from the UCLA School of Nursing. These students are what we call MECN students, Master's Entry to Clinical Nursing. So they'll come out ready to take their nursing exams and a master's degree. So they're advanced students, and we really hope that we can bring you some useful information as you work with clients in the field.
Great, thank you, Elizabeth. All right, first up on the agenda, Sadie, you're up.
All right, I'm just gonna share my screen. One moment. Bigger. Okay. So, hello, my name is Sadie, and today I will be presenting on sexually transmitted diseases. And for the purpose of this presentation, I will be referring to biologically male genitalia and biologically female genitalia in reference to signs and symptoms seen in various STDs. However, I would like to make it clear that STDs affect individuals of all gender identities. So, sexually transmitted diseases, otherwise referred to as STDs, are bacteria, viruses, or parasites that are spread through sexual contact. STDs can spread through any and all sexual partners, or between, I should say, any and all sexual partners, and they're spread through direct oral, anal, or vaginal contact, and through contact with semen and vaginal fluids. These organisms cause an infection. An infection is often the first step of a disease and occurs when the bacteria or virus enter the body and starts multiplying. The disruption of normal body function or structure, especially when signs and symptoms appear, is considered disease. So medically speaking, sexually transmitted infections or STIs progress into sexually transmitted diseases. However, it's very common to hear the term STI and STD used interchangeably, as STI carries a less negative stigma. However, for the purposes of this presentation, I will be using the medical term STD. So there are multiple different kinds of STDs, but these are a couple of the most common in those experiencing homelessness. I've categorized them within these three types, as these categories pertain to the type of treatment they often require and the symptoms they can cause. So in our first category, we see chlamydia, syphilis, and gonorrhea are bacterial in origin. Trichomoniasis originates from a parasite, and HIV, herpes, and human papillomavirus, also referred to as HPV, are viral in origin. So what do these STDs look like in the field? So for chlamydia, this can look like discharge from the penis, which is white and cloudy and watery in consistency. It can also look like burning with urination, testicular pain and swelling, and abnormal vaginal discharge that looks yellowish and has an odor. For gonorrhea, this can look like painful or burning urination as well, swollen testicles, anal itching, soreness, or pain, and a yellow, white, or green discharge. This can also look like bleeding between menstrual periods and an increase in vaginal discharge with a foul odor. For syphilis, this can also spread via blood, for example, when needle sharing with an infected person. And this can look like painless sores or open ulcers that are found in the infected individual's mouth or on the rectum or genitals. and they usually appear within 2 to 3 weeks after having sexual contact with an infected partner. However, if it goes untreated, it can lead to flu-like symptoms such as fever and large lymph nodes, soreness and aching, and it can also progress to a rash marked by red bumps over the body. Trichomoniasis, you will notice, is not on this. It originates, as we said, from a parasite, and it wasn't included on this slide because many people actually don't experience symptoms. However, if symptoms do appear, it looks very similar to the symptoms seen in chlamydia and gonorrhea. And with all of these, including trichomoniasis, if caught early, they can be treated with oral antibiotics. So as stated before, HIV, human papillomavirus, and herpes are viral in origin. Therefore, unfortunately, unlike the STDs in the previous slide, these viral STDs don't go away, but their symptoms can be managed through medication. So HIV stands for human immunodeficiency virus, and it's a virus that attacks the body's immune system. So most of the symptoms that you may see with HIV are not directly caused by HIV, but an infection or other condition that is brought on by the fact that this virus causes a weakened immune system. Therefore, these symptoms can look like fever, swollen glands, fatigue, headaches, and pain in muscles and joints. For HPV infection is one of the most common types of STIs, and some forms of HPV put women at high risk for cervical cancer. Other forms cause genital warts. HPV usually has no signs or symptoms, which is why prevention methods like regular pap smears are important, and we'll talk about prevention methods on another slide. However, the signs and symptoms of genital warts can include small flesh-colored or gray swellings on the penis or vagina, several warts of a cauliflower shape, and itching or discomfort on the penis or vagina. Warts can also develop in the mouth or throat of a person who has oral sex with an infected person. And for herpes, this is a highly contagious STD. It's caused by a type of virus that enters the body through small breaks in the skin. And there's two types of herpes. There's one which usually shows up as cold sores or blisters on the mouth, and another which is often referred to as genital herpes. So most people with herpes also never know they have it because they have no signs or symptoms, or the signs or symptoms are very mild or go unnoticed. However, early symptoms of herpes can include burning sensation in the genitals, low back pain, pain when urinating, and flu-like symptoms. And if this goes untreated, later these bumps can become painful, or it can cause small red bumps that appear around the genitals, and those bumps can become painful blisters. So I know that was a lot of information about all different types of signs and symptoms. So to recap, I've put them into 3 different categories here for red flags to look out for. So if you have developed rapport with a client and they are talking or express that they are having pain, so pain with urination, lower abdominal pain, or pain with sex, this can indicate they have an STD. If they are speaking to you and say, you know, I've noticed something unusual or something different for me, I'm having foul smelling genital discharge, unusual vaginal bleeding, oral, rectal, or genital sores, or a rash over my trunk, hands, or feet, that's another indicator. And fever is another indicator. And that's because when our body has an infection, fever is often one of the big signs of that. And you may not have a thermometer out in the community, but this can look like sweating. The patient may feel very warm, or chills. So I also included here on the right different questions to ask when you are talking to a client. So you could ask if they have pain or a burning feeling when they pee, Are they having pain in their stomach area? This is their lower abdominal area. Are they having pain with sex? Do they notice unusual or odd smelling discharge from their genital area? Are they experiencing unusual vaginal bleeding? Do they have sores or bumps in their genital, mouth, or rectum area? And are there sore, swollen bumps along their underwear line? And this last question here is pertaining to sore, swollen lymph nodes, which is an organ that is part of our immune system, which usually keeps us healthy, but when it gets infected, can become swollen and sore, particularly in the groin area. And that's where we're referring to along the underwear line. So I included this slide here because, as you can see, it often can take a while for symptoms to appear, if they appear at all. So prevention methods are really important to use. And the biggest prevention method that can be used to prevent STDs is actually testing, because many of the sexually transmitted diseases don't have symptoms. And I wanted to describe what testing looked like. So if a client did feel comfortable going or had some questions, you guys would know what it looks like. It often involves peeing in a cup, taking a swab of fluid from the infected area. In the case of HIV, blood testing, so taking a blood sample. And in the case of HPV prevention, having a pap smear. And pap smears are generally recommended every 3 years for women between the ages of 21 and 65. There's also vaccination. So there's the human papillomavirus vaccination, which can be given to individuals between the ages of 9 and 26. And it comes in 2 doses that are 6 to 12 months apart. And this prevents the type of HPV that can cause genital cancer. And there's also the hepatitis B vaccine, which can be given if it hasn't been given at a younger age. In terms of medication, so for the STDs that are bacterial in nature, those can be treated with antibiotics. But for those that are viral, there's a medication called PrEP, which is an oral medication, 1 pill a day, and it's used for HIV prevention. So an individual has to be HIV negative to take it, and it is something that has to be taken every day, so the upkeep of that can be difficult if there's not really a place to store that medication, but that's also an option. And last but definitely not least is safe sexual practices. And this involves with oral sex, vaginal sex, and anal sex, using latex condoms, dental dams, and although it's not possible for all, for some, having sex with one partner. So that is everything on my presentation, and I would be more than happy to take questions now, and I can stop sharing. There we go.
Any questions? Anything anyone is dying to ask or dying to know? Now's the time.
I also have a 1-page flyer that kind of summarizes all of this that I'll send out.
Excellent. All right. Okay, if there's no other questions, there also will be time at the end to ask any questions if you want. Other than that, thanks so much, Sadie, and Briana, you're up next.
Thank you so much, Carrie. I'll share my screen now. All right, can you see my presentation? Do you also see the notes? No?
Nope, you're all good.
Good. All right, so good afternoon, everyone. My name is Bree, and I'm also a UCLA School of Nursing student. Today I'm going to be talking about skin health, particularly open wounds. Just as a warning, there are some pictures of some pretty nasty wounds in this presentation, so if you need to step away at any point, do so. And also, this is in no way comprehensive, so if you have any questions or concerns about specific clients, I really encourage you to talk with the nurse at TPC or other healthcare provider. All right, I'll start about talking about different types of wounds that you might commonly see or maybe have already seen in outreach. And then I'm going to describe some important red flags to look out for and give you some suggestions on how to treat and prevent wounds in clients experiencing homelessness within your role as an outreach worker. All right, so there are a lot of different types of wounds, and it can help if you ask the client first how they got the wound, but you won't always necessarily know everything the client's been through, or they might not be comfortable telling you. So you might just have to do your best without knowing where the wound came from. So here are some general guidelines for how to identify different types of wounds and what might cause them. So the first type of wound is the type we probably all normally think of, wounds that result from injury or trauma. And these wounds can take a variety of different shapes and degrees of severity. But sometimes you can figure out the cause of the wound based on the shape. So for example, an animal bite will have distinct teeth markings, road burn might look like a dirty scrape, and other cuts or stabs might reflect the objects that cause them. But these kinds of injuries can be hard to distinguish because they can occur on any part of the body, although the common sites of injury are the head, arms, and legs. But generally, the approach for all these wounds is the same. We want to keep them clean and covered. If the wound is actively bleeding though, be sure to put on some gloves and then grab some gauze or something absorbent and apply pressure to the wound. If the cut is deeper than ½ an inch, if the bleeding doesn't stop with direct pressure or continues after 20 minutes, that's when it's really important to seek medical attention from a nurse or urgent care. The wound might need stitches and other help, and head wounds in particular tend to bleed easily. So that's just one thing about traumatic wounds. Another common wound you will likely see in outreach are these circular wounds on the top right. These are the result of injection drug use, where the person might inject drugs under their skin or into the muscle, which is a practice known as skin popping. These will commonly be found on the arms and legs and are very high risk for infection because unclean needle use and impurities in the drugs might cause this tissue damage and infection. So these are ones to look out for these red flags that I'll talk about in the next slide. Another common wound is caused by prolonged swelling in the lower legs. So these wounds form when circulation is bad and blood pools in the feet, which causes the skin to break down. These are common in people with heart disease and who spend a lot of time on their feet. The last type of wound is commonly seen in patients with diabetes. So diabetic people who are unable to control their blood sugar commonly experience this loss of sensation in their feet because of nerve damage. And losing sensation in the feet really just puts you at a higher risk of getting cuts and injuries because you just can't feel it. And people with diabetes also have poor circulation to their feet, which makes it a lot harder for them to heal the wounds. So it's like a double whammy of not feeling and then also not healing well. All right, so while many open wounds can be cared for out in the community, there are certain situations where you should tell the client to see a nurse or other medical professional. So I'll describe some signs that things aren't healing properly. First thing you want to do is look at the color of the wound, if the inside of the wound is visible. A warm red color is healthy, so here come the pictures. A healthy wound bed typically is described as like a beefy red appearance. But if the wound is really dark or almost black, that's a bad sign. Black in the wound is a really big red flag because it means the tissue has died. So in order for the wound to heal after it becomes like this, the dead tissue has to be removed, which can be performed by a nurse or other healthcare professional. Like, you probably shouldn't do that. And if there's the wound is yellow, this is also a sign that the wound is healing slowly and can be at risk for further damage. Another red flag is odor. So a bad, foul-smelling wound commonly means there's bacteria present and the wound's infected. So if there's a bad smell, the client probably needs the wound to be cleaned and will likely need antibiotics. Another thing to pay attention to is drainage. So if the wound is producing thick yellow, green, or brown drainage, this is a sign of infection, which is the example of the bottom left. That is the infected drainage, and then the other three, the pink, white, and red, those are all normal forms of drainage that might be okay. But obviously, if there's a lot of heavy bleeding or lots of drainage, that's probably something that needs to be addressed. All right, so next thing, and here's a picture of an infected wound with lots of drainage. So next thing to look at is the surrounding skin. What color is it? Is it the normal skin tone of the client? If the skin is reddened, ruddy, or darker than the client's normal skin tone, it's possible that the client has cellulitis, which is just an infection under the skin. And this can occur without the presence of an open wound. Might happen after a bug bite or injection drug use or other small breaks in the skin. And here are some pictures of that. So this is on white and darker skin. And an infection like this is actually a really big red flag because it can spread really quickly to become life-threatening. So it's really important that clients get access to antibiotics if you see the sign of cellulitis. And if you're not sure, it's always good to ask for help from the TPC nurse. All right, and so when you're looking at the surrounding skin as well, if the area is particularly raised or bulging more than the surrounding skin, an abscess might be present. Abscesses are accumulations of pus and inflammation that should be drained. And this should be done by a nurse or another healthcare provider. They'll numb the area with some medication before cutting it open, and they'll do it cleanly. And some clients will do this themselves. Here's some pictures of abscesses. Yeah. And then the last big red flag that is probably the most important and potentially life-threatening is the presence of fever. So if the site of the wound is hot, swollen, and the client generally has a fever, they might also have signs like sweating, they might be having chills or shaking, they might be breathing heavily, or they just might generally be confused. Those are all signs that the infection is spreading throughout the body. And so at that point, it's really important to seek help. But in summary, if a wound is healing properly, it will have beefy red tissue, clear or pink tinged drainage, no foul odor, and the surrounding skin will look normal without redness, heat, or swelling. All right, so in that case, if the wound is healing okay, then it's okay for you to provide support to the client in caring for the wound if the client's capable of helping themselves. But some general goals of wound care to keep in mind are that we just want to keep it clean, slightly moist, and avoid infection. So keeping it clean means washing it with clean water and using clean supplies to cover it, like gauze and paper tape. Keeping it lightly moist means that you don't want the inside of the wound to dry out, but you also don't want it like damp or soaking wet. We just want it a little moist. So if the wound's too dry, it can help to apply some antibiotic ointment like Neosporin, and then cover with gauze or Band-Aid. But if the wound is too wet, you might want to use some foam gauze if you have access to it, which can help soak up that excess drainage. And then also to avoid infection, the client should observe basic principles of hygiene. Obviously, this may not be possible if they don't have access to clean water, but if they can wash their hands before and after touching the wound, that's best. Sorry, in summary, if the wound is too wet, dry it. If it's too dry, moisten it. If it's too deep, pack it. And if the tissue is dead, remove it. And those last two are more for nurses. Those are nurses' interventions. And this is just some advice from the National Healthcare for Homeless Council. All right, and then in addition to the basic wound care goals, we also have some supportive goals that can help the client heal faster. So you want to encourage the client to get as good nutrition as they can. So encouraging them to eat protein with enough calories, and controlling their blood sugar is especially important for clients with diabetes, which one of my colleagues will talk about in just a bit. And then for some wounds, like wounds on the legs and feet, it's really important to encourage them to relieve the pressure and elevate their feet. So I'm sure you know better than I do that how difficult it can be for clients to have the time and situation that allows them to elevate their feet. But if possible, you can encourage them to do this because rest is really important for wound healing. All right, then lastly, just have some prevention steps. So generally, have your clients stay warm and dry if possible. Avoid wearing wet clothing. If you can provide them clean, dry socks, that's great. Reducing the risk of infection with needle exchange and other harm reduction practices. That's another great way to prevent injury and prevent wound formation. Avoiding injury by getting shoes that fit, avoiding being barefoot, and then generally having good nutrition with proteins and vitamins, controlling blood sugars, and promoting rest. So connecting the individual with shelter or resources, that's one of the best things you can do. Thank you so much for listening, and I hope that you learned something today. And here are my references.
Thank you, Briana. That was very informative. Are there any questions, comments, general musings? Going once.
I have a question. So I have a client here who has a kind of like a big sores on his one of his foot, and we encourage him, to go to the ER all the time. And he went one time, but he left. But I really don't know what to tell him at this point, like how to help him get better. Maybe you guys have some advice.
Can help me on that one for that specific client.
Does she have a primary care physician?
I don't think that. I think we're working on getting him a primary care doctor. Yeah. Right,
because I would take a look at it, and if it's infected, who is the doctor that works with you there?
Well, the PA is the one that recommended that he go to the hospital, like, right when she saw him, because I don't think that he had a primary care physician. And he did go, but I think he left before they were able to treat him. But he was only there like a day. So he left on his own.
For right now, I don't know if the PA should, like clean it up and wrap it, but what you can do is take a picture of it and send it to the PA, because it sounds like probably needs antibiotics, or if it's really infected. I don't know if he has diabetes and it's diabetic, ulcer wound. Yeah. So, I would at least, get a photo of it and send it to if the patient consents to that, and send it to the PA.
Okay, I'll do that. Thank you.
Great question. Thank you, Michelle. And thank you, Eileen, for your guidance. Up next, we have Summer. So whenever you're ready, Summer, take it away.
Okay, can you guys see my screen?
Mm-hmm.
Okay. All right, well, hello everyone. My name is Summer Buckley. I'm a UCLA nursing student, and today I'll be talking about mouth health. If at any time during the presentation you have any questions, please just keep them towards the end, and then we can discuss at that time. So let's get into it. So mouth health refers to the health of the teeth, gums, and the entire oral facial system. And this allows us to smile, speak, and chew. So today I'll be discussing 4 of the most common mouth issues that are seen within the homeless population. These factors to consider are METH mouth, cavities, missing teeth, and gum disease. So METH mouth is defined as a severe tooth decay and gum disease, which often causes teeth to break or fall out. And cavities are decayed areas of the teeth that develop into tiny openings or holes. Missing teeth is the absence of one or more teeth due to poor hygiene or a drug side effect. And then lastly, gum disease is the infection of the tissues that hold your teeth in place. Next, I will show some example pictures of what these factors look like. They're a little graphic. So this is METH mouth. And as you can see here, the areas around the gums are rotting and they have signs of irritation. And on the bottom row, you can see how the gums are starting to break apart as well. Next, we have cavities. This is a severe case of cavities. You can see some of the teeth are rotting away at the bottom and towards the top. And then you can also see the decay at the root of the teeth as well. Next, we have missing teeth. And although this is self-explanatory, it looks different in different people. So here you can just see the entire gum. There's no root from the tooth or anything. And then lastly, we have gum disease. And you can see the gums are starting to, and some have already deteriorated. And this bottom picture is an example of a gum disease that went untreated and is identified as mouth cancer. So we can get into some risk and then discuss some causes of these factors. So who's at risk are those who don't have access to regularly scheduled dental visits, people experiencing homelessness, and those who don't have access to dental hygiene supplies. Some causes of poor mouth health is failure to brush and floss regularly, having a poor diet, such as like eating sugary and acidic foods, chronic smoking, and or the use of methamphetamine. So now let's talk about some red flags. First, we have chronic bad breath, and this is caused by gum disease, certain foods, and excessive drinking or smoking. We then have bleeding gums, which is caused by vitamin K deficiency. And this just means that this vitamin helps your blood clot properly. And if you don't get enough through your diet or your body doesn't absorb it well, it can cause bleeding in areas such as your gums, as well as gum or tooth-related infections, poor oral hygiene. Then we have dry mouth. This is caused by infections, some nerve damage, depending on where it's at. It can affect the salivary glands, which cause it not to function well. Also dehydration and smoking. We next then have loose teeth, and this is caused by the use of street drugs, poor oral hygiene, infections, and also aging or osteoporosis. Mouth sores can be caused by incorrectly sized dentures or leaving them in for too long. It can also be an indication for oral mouth cancer as well, and then food choices as well. And lastly, we have the sensitivity to temperature. This is caused by the loss of enamel, which is that outermost layer covering on your teeth, smoking, improper dental care, and then food choices as well. So as you can see from all of these red flags, there's some common factors: infection, not brushing and flossing regularly, food choices. So here are some things that we can do to help. So one, you can provide soft foods like yogurt, applesauce, and soft fruit cups. And this is just because the damaged teeth can be painful for most and uncomfortable when chewing and eating. So soft foods are more likely to be easier for them to eat. Next, you would want to supply oral health supplies like a toothbrush, floss, and toothpaste. So oftentimes, those experiencing homelessness don't have access to these supplies. So this could be something that you all could do. Next, you can assess your client's mouth for bleeding and swelling and for pain. And on the next slide, I'll go into a tool that could be helpful for that. Next, you can assist them in helping them with their oral health schedule. You can encourage them on why it's important to brush and floss regularly. And then lastly, you would want to connect them to dental health services as well. So lastly, I just want to share this oral health assessment tool. And it basically determines what your next steps would be. So on the left-hand side, it's categorized in the most important categories when assessing oral health. You would then mark the number on what you observe and what you see, and your score will determine whether or not they need an intervention or a referral. I thought this would be helpful because sometimes we don't know exactly what we're looking for or what would be most important. So yeah, this is a good handy tool. Yeah, so this is the end of my presentation. I hope you guys learned a little something and you enjoyed it. At this time, I'll take any questions.
That was really good, Summer. I just wanted to share that like meth mouth, which is like really common. We hear that a lot now since meth use is just running rampant. But meth mouth is also, it's the same as with heroin. Heroin users have meth mouth and they'll lose their teeth and have a lot of tooth decay. The same, you know, in the same pattern, the same way with heroin use. So that's, you know, and it's something we see a lot, you know, on the streets and everything. So just to share that with you, it could be heroin or meth.
I have a question about that for whoever. Is there a way to prevent, so our clients that aren't going to stop smoke, because like, okay, harm reduction, if they're using needles, one of the things that we can try and encourage them to do is snort safely, smoke safely, and unfortunately what that leads to is the meth and, you know, the rotting teeth. But is there a way to prevent it, knowing that they're not going to stop smoking meth or heroin or whatever the heck they're smoking that's going to rot their teeth? Are there things that we can do to or things we can encourage them to do that will either slow down or prevent the rotting meth mouth?
Well, I think always, like if they had followed, I mean, it's not followed a regular, you know, brushing their teeth and flossing, but usually if you're getting high, that's not high on your list a lot of the time, to floss and brush, but also right. And regular treatments. But, you know, a lot of the time with meth mouth and with heroin, it's that craving, that sugar craving that you have, and that increases it as well. You know,
I see.
So, yeah.
And Grace and Dr. Dixon both said, so rinse mouth after eating. Okay. And then chewing gum and keeping, okay. All right. Those are good things that we can encourage people to do, even if, you know, chewing the gum, if they're not going to brush their teeth, or we can always hand out, we get those little bottles of mouthwash sometimes that we can start handing those out too.
I mean, it's interesting, you know, with meth mouth that no matter how, whether you use that drug anally, if you smoke it, inject it, snort it, still meth mouth. You're still meth mouth. So that's kind of interesting too.
Huh. All right. Well, thanks.
How much someone have to use for it to affect their teeth?
It's hard to say. I think it's pretty individual. I mean, I have no idea. No idea. I think it depends on the individual, I guess. I mean, I've seen people that are meth users that have like no teeth at all. And then I've seen meth users that have been using forever and their teeth are okay. So it's really hard to say. That's a tough question.
All right, lots of really, really good questions. Any other ones before we move on to our last presentation? All right. Okay, thank you. So up next is Anna. Take it away.
Hey, Anna.
Hi, everyone. My name is Anna, and I'll be talking with you today about how to speak with your clients about diabetes. So I'm just going to get my slides ready to go. Can everyone see that okay? Cool. And you're not seeing my notes, is that correct? Beautiful. Okay. So as I said before, my name is Anna. I'm a nursing student at UCLA, and I'm here to speak with you today about how you can talk with your clients about diabetes. And today what we'll talk about is what diabetes is, what are some red flags to look out for, what you can do when you see those red flags, and then how you can help your client prevent issues in the future. So first, what is diabetes? So if you take a look at the top right of your screen, I really like all these words all jumbled up here because I think it shows how complicated diabetes can seem. You know, we hear a lot of words thrown around about diabetes: insulin, glucose, type 1, type 2, pancreas, a lot of different things. And so what I'm here today to do is to try to break it down as simply as possible and just to give you a broad overview about how you can help your clients with diabetes in the field. So diabetes, what is it? To start, when we eat food, it turns into sugar in our blood. And sugar is important because it helps to give our body energy to do what it needs to do. And so sugar is traveling around in our blood and then it goes into our cells to do its job. The thing about diabetes is that the body has trouble keeping the amount of sugar in the blood at a safe level on its own. And so because of this, the person is at risk for having too much sugar in their blood or too little sugar in their blood. And both of these situations can actually be dangerous. So next I'll talk about how to tell when either of these two dangerous situations might be happening with your client. So this slide shows the red flags to look out for, both for high sugar and for low sugar. And these are things that we call diabetic emergencies because they can be very serious. So high sugar is on the left side of your screen, and that might look like the client complaining about having a really dry mouth. They might be really thirsty more than they usually are. They might have blurred vision. They might be feeling very weak or complaining of a headache. And then they might be having to pee a lot. And then when their sugar is really, really high, you might even notice that their breath starts to smell kind of sweet or fruity. They might be confused. They might be breathing really deep and fast. Or you even might see that they've peed on themselves. So these are all red flags to look out for that something might be going on with high sugar. And then on the right side, we have low sugar. So that looks like maybe the client's sweating, they're pale, they're kind of uncoordinated, they might be really irritable, they might be more hungry than usual, or they might be sleepy. And then when the client's sugar is very low, they might be really confused, or they might even be unconscious. And this is really tricky because all these symptoms, you know, maybe that will be something that the client looks like when they're intoxicated too. So you have to really, really know, and you have to ask questions to see what's going on. And that's why the next slide is so important, because we can figure out what to do, because we can't always assume that what you see here is diabetes. So you see a client who has one or more of these red flags of either high sugar or low sugar, and then what can you do? So like I said, it maybe is not diabetes, and that's why the number one most important first step is to actually ask your client, have you ever been told that you have diabetes? And then if the answer is yes, then that's a big clue that it might be a diabetic emergency that you're looking at. And if so, you'll want to try to get what's called a finger stick to check the blood sugar level. And there's a picture of what that can look like on the bottom left of your screen. Basically, it's a little needle that pokes your finger and then some blood comes out and you test the amount of sugar in your blood. So often clients might have these in the field to check their own blood sugar. And in that case, you can advise the client to take their own sugar. But if your client doesn't have this, then the nurse can also help your client to get that finger stick. But either way, you'll want to call the nurse at the people concerned if you're seeing these signs and if your client says that they've been told they have diabetes. And then similar to the last slide, this idea of what we can do can be divided into high and to low sugar. So for high sugar, it's really important to have some measure of what their blood sugar is. And that's with that finger stick that we talked about. And then if you can ask them if they use insulin, and if they do, then you can help them to locate it if their blood sugar is really high. And then on the right-hand side for low sugar, the goal here is to give them sugar so that their sugar rises. So first check to make sure that they're conscious and that they're able to swallow, because we never want to give them anything in their mouth if they can't swallow okay. So if they can swallow, then you would give them some juice. So that can be like orange juice, apple juice, or you can give them hard candy. And it's important to know that you want to make sure that this candy is not sugar-free, because the goal here is to up their sugar. So this is something that's like a small thing you can carry with you, and that might be good to keep on hand while you're doing outreach. And then the thing is, if the client cannot swallow, so you can't give them that sugar in the mouth, or if they're unconscious, that's really dangerous. And that would be a time that you'd be wanting to call 911. All right, so we've already talked about diabetic emergencies. So that's, super high or super low sugar, and what you can do if you see someone who has those emergencies. And then now I want to quickly talk about some of the other red flags that you can look out for that will be clues that maybe the client is dealing with diabetes, even if it's not a really urgent thing in the moment, like those super high or low sugars. So some of these clues include infections that just keep happening. Also, if their gums are bloody or swollen, if they have wounds and those wounds are not healing. So you've seen them before, you keep coming back and those wounds are not healing. And then also if they're saying that their hands or their feet feel numb or tingling, that's a cue that maybe diabetes is going on. So these are all red flags that maybe it's diabetes that's happening. And we know that this presentation is all about harm reduction. So we're assuming that the client won't necessarily be going into the hospital. But if you see these types of things in your clients, this can help you to keep an eye out for future issues. And it can also help you to try to teach your client how to prevent those diabetic emergencies that we talked about. So finally, now that we know the red flags for diabetic emergencies and diabetes in general, let's talk about how you can maybe play a role in helping your clients to prevent these issues from happening to begin with. And this prevention is really all about education. So here it helps for us to think about it in two categories. So on the left, we have medication, and on the right, we have diet. So for medication, you can ask, do you take medication for diabetes? Because not everyone does. So it's important to ask that. And then if they say yes, and they say that it's a pill that they take, you can encourage them to try to take it their best they can as their doctor prescribed it, because that'll help to keep their sugar at a safe level. And then if they say that they do take medication and that medication is insulin, then there's a couple things that you can advise them on. So number one, you want to educate them to check their blood sugar before eating, because this is something that many clients need reminding on. And then number two, because we know that food might not always be readily available to these clients, you can tell them that they should use less insulin when they have less food available. So that's kind of a harm reduction approach here. And then finally, you can encourage them to store their insulin in the coldest place possible, because insulin needs to be kept cold in order to do its job right. So the nurse has a fridge at the people concerned, and that's the best option to use because that's the coldest place to store something. But if that's not available for some reason, there are some other options. So for instance, you can advise the client to stick the insulin in a more outer pocket instead of really close to their body, because that might be a little less warm. So that's all just kind of a harm reduction idea. And then moving on to diet, we know that it's not realistic to necessarily say that folks should eat 3 meals a day that are perfectly nutritious, because we know it might not always be in their control of where they're getting their food or what they have access to. So that's why we want to make sure that we use the harm reduction approach and help them make the best choices possible with what's available. So you can ask them the question, how do you usually get your food? And sometimes folks will usually get just 1 meal a day, and that's how they primarily get their food. And in that case, you can encourage them to spread the food out throughout the day, if possible, to try to keep their level of sugar in their blood at a more stable level. And then finally, we can say that when there are options available to your client, that they should try to make the best food choice possible with what's available. And that might look like aiming more for veggies and fruits, more lean proteins. And so one example here is, if a shelter is serving mac and cheese and veggies, maybe eat a little more of the veggies and a little less of the mac and cheese, those types of things. And then some snack ideas that you can give clients are protein bars. You can advise them to eat nuts or beef sticks, like beef jerky sticks. But you want to make sure that there's no sugar added to those, because that's important to keep in mind. All right, well, thank you so much. This is my last slide, and I have some references here with some good information that you can look up more about. There's some information about diabetes among clients experiencing homelessness. and then I can go ahead and take any questions.
Anna, that was really good. Your was really good. I think now the insulin, most it's prescribed in the insulin pens, so which don't have to be refrigerated all the time. So it's just much better than the vial, you know, drawing it up that way. And it's hard, like what you were saying, I just wanted to mention, like, if you're going to eat less, use less insulin. I mean, it's like, as nurses, we don't change the insulin dosage. You know, a sliding scale is set, or they have a set, you know, counting carbs. So like out on the streets, usually it's pretty much set. So, you know, like how many units you're going to take in the morning and before meals. So like when we were talking this morning, like I'm not going to encourage anybody to change their dose. You're going to just stick with that dose that the doctor, you know, gave them, because it's really tricky with insulin. Like I never want to mess with anyone's insulin or change the dose or anything else. But, you know, really when you're out in the field, it's, if somebody's asymptomatic, we're not going to really do anything. And that's what's challenging, as, you know, you being a nurse and I'm a nurse, to look at somebody who's like, their blood sugar is like 500, but they're not symptomatic. So we're not really going to do anything. And like we know in the hospital, it would never be like that. You know, you'd call the doctor, you'd give this, do that. So, you know, it's interesting how like out on the street and outside, how people aren't symptomatic, you know, and we can look at somebody if they're low and, you know, get them some juice or something like that. But it's different when they're high. You know, it's very challenging. I feel it's challenging, you know, dealing with that.
Thank you, Anna, and thank you, Eileen. Is there any more questions?
Yeah, and I just want to say thank you so much, Eileen. That's really, really helpful. And I think that you know, that's really great advice to try to stick to what the doctor has prescribed. And then probably some good advice for folks on outreach is deferring to you for your advice in the situation. And, you know, I think that's a great idea to not be suggesting that they change it. So I can also change my recommendations for the sheet I'm making to keep it more, you know, like do what your doctor orders. Yeah.
All right, I'm gonna go ahead and stop this recording, and thank you for watching.